This conference will now be recorded.
And after that, here there will be short panel questions. We will also have the invitations for the dinner function that you can review. We'll be in that room behind there. The faculty all are invited already for that dinner. Dr. Patel will talk of also seeing me at the program. If you haven't signed for that, you might still ask for the girls if you want, if there's still some more doubts on it. Manette, all yours.
Good evening. I'm just impressed with the people who have stayed to the end, and now we are rehabilitating. So I'm going to be talking about Cardiac Rehabilitation 2019. These are my disclosures. And let's start with a definition, which has not changed since we did the original public. It doesn't. Thank you. It doesn't want to let you see it. Now you really can see it together with me. The definition really has not changed since we officially gave this to the AHCPR in 1995. And that is, this is the provision of comprehensive long-term services involving medical evaluation, prescriptive exercise, risk factor modification, education, counseling, and behavioral interventions. And the goals have really not changed either: to limit the effects of illness, to reduce sudden death, to control symptoms, to reverse progression, and enhance psychosocial and vocational status. But what has changed over time is the who, what, where, when, and why. And that is what we will review together. Remember that in the 1960s and 1970s, cardiac rehabilitation occurred predominantly in Europe. And this was residential rehabilitation in the countryside. They were wonderful castles in the Black Forest. It was almost worth having an infarct to be able to go there. And typically, it followed several months of hospitalization for myocardial infarction. And there was supervised exercise, not monitored, supervised. Someone walked with the patients as they climbed the hills. And there was education and counseling. But there were some major concerns because these individuals were away from family and friends, and there were challenges with readjustment to society, question of could they return to work. They started some exercise clubs in the communities, but the costs were enormous and the availability was limited. And then in the 1970s and 80s, cardiac rehabilitation moved to North America. And we were very pleased at Emory and Grady in that in a public hospital in the Deep South, we were the center to start early ambulation after myocardial infarction. We had originally a 20-some-odd step program, and as the hospitalization decreased, a 14-step program. And what we dared to do in the 1970s was to send patients home from the hospital after 21 days. That was called early discharge. And then what was seen in the North American continent was outpatient rehabilitation. Some was hospital-based, some was community-based, but initially nothing happened after going home for 4 to 6 weeks because people were just afraid. But there was exercise testing and prescription, and then with time there came ECG monitoring and clinical practice guidelines. But what we've seen is evolving indications. Early on, these were just after recovery from myocardial infarction. And now, at least as of 2017, AMI, bypass surgery, stable angina. Remember, if patients have not previously had rehab, you can just prescribe this from your office. PCI, heart valve surgery, heart-lung transplant. More recently, chronic congestive heart failure, but it must be systolic dysfunction. Not yet in their ultimate wisdom, has CMS approved it for diastolic heart failure and most recently symptomatic peripheral arterial disease. But what we're seeing now is an entirely different spectrum. We're seeing rehab for patients who were previously arbitrarily excluded, heart failure, arrhythmia, pacemakers, ICD. And now we're seeing exercise training as a component of anti-anginal therapy. We're seeing more elderly patients. We're seeing a more diverse population. And I think we have to say that exercise training is a component of rehabilitation, but it's not total rehabilitation. There has to be education, counseling, psychosocial issues, and important now is return to work as an economic imperative. We're beginning to see from the professional societies performance measures about structure and process. Some are designed for hospitals, some for offices, some for rehab. And I'll just give you an example. This Thomas paper is excellent, and it has almost any form that you might want to use in the office or in a rehab setting or in a hospital. But the problem is participation. Even though there's a 1A recommendation in almost every one of the clinical practice guidelines for rehab, we have data that no more than 14 to 31% of eligible Medicare beneficiaries participate. That's where our best data is. And therefore, people began to explore what are the barriers to participation and how can we overcome them. I'll show you a list of barriers and why it's important to overcome them. Female sex, older age, minority, limited access, low SES, low self-efficacy, low health literacy, lack of perceived need, language issues, cultural, work-related, limited social support, home relationships. And those are just the patient barriers. Then there are the medical barriers of comorbidities, including depression and musculoskeletal conditions, health system barriers, lack of referral, limited enrollment, physicians not endorsing it, patient-provider relationships, and then program characteristics, lack of programs in specific geographic areas. And I'm seeing this from the wonderful lunch talk we had about barriers of access to care. Distance from home, hours of operation, transportation, lack of racial and ethnic diversity among the workforce, and gender-dominated programs. So with all these barriers, how do you balance that with the benefits? Cardiac rehab in all the trials shows improvement in exercise tolerance, symptoms, lipids, cigarette smoking reduction, psychosocial well-being, reduction of stress, and reductions in mortality, recurrence, and revascularization. Now, if that were all put into one pill, we would all be taking it every single morning. But the fact is that this requires cardiac rehabilitation. The benefits of exercise training on exercise tolerant aerobic capacity, strength, endurance, it helps maintain independence for older adults, and that's extremely important for your elderly patients. It improves lipids, blood pressure, etc., decreases CRP, improves endothelial function. And the clinical trial data show that 22 RCTs of exercise training decreased mortality and fatal reinfarction. And that's what got the approval early on. But the fact is that most of these RCTs antedated all of the contemporary medical and revascularization therapies. So reasonably, people said, is the magnitude of benefits similar in a contemporary environment? Cochrane database, now this goes back to 2001, decrease in mortality, but no effect on recurrent non-fatal infarct. But this looked at a low risk, predominantly white male population, and medications were not well tolerated. Again, we began to have more meta-analyses. In 2004, this one included women and the elderly and revascularized patients. And again, a decrease in all-cause and cardiac mortality, but non-significant but favorable trend for non-fatal MI. And exercise rehabilitation, both with and without risk factor education, lowered cholesterol, blood pressure, decreased smoking. No differences in many other endpoints. But getting more and more current. 2005, looking at some 21,000 patients in 63 RCTs, benefit with and without supervised exercise. But as we have longer follow-up, a decrease in recurrent MI, and then beginning to see a survival benefit. So what we see is that even with the contemporary therapies, 2 decades later, we see the same benefit and same magnitude of benefit from cardiac rehab. And again, the AHRQ, when we did the review, 18,000 patients, 46 randomized trials, less hospitalization, less recurrent MI, and a decrease in long-term mortality. Now, here's what one of the mechanisms may be. Each 1 MET increase in exercise capacity associated with an 8 to 35% decrease in mortality. So when you increase exercise capacity, all of the things that go with it seem to lessen mortality. And of course, this compares very favorably with the survival benefits of what? Aspirin, statin, beta blockers, and ACE inhibitors following myocardial infarction. Seeing much more 1-year survival free of cardiac events. And, depression is such a common problem that we see following infarct. And the mortality in depressed patients as compared with non-depressed was 22% compared with 5%. But there was a 73% in mortality of the depressed patients related to cardiac rehabilitation, and it seemed to track the improvement in physical fitness. Meta-analysis for heart failure, which is the beginning of the approval for heart failure, improved functional capacity, fewer symptoms, and a trend, but not definitive, improved survival. So I'm not going to detail the benefits of exercise, but it's an anti-atherosclerotic intervention with the benefits that you see listed on the slide. It's an anti-ischemic intervention, again with this list of benefits, anti-thrombotic, and anti-arrhythmic. So there are multiple benefits of the exercise training. And important is the safety, because again, major cardiac events, very low, and in 2007, the AHA scientific statement showed that any major complication between 1 to 60 and 80,000 supervised exercise. And then the question comes about, well, what about unsupervised exercise? And we'll come to that. Contemporary French registry, even a lower incidence of events. But remember, these are now revascularized, medicated patients. Psychosocial problems really important for rehabilitation, because what do we see in these patients? Depression, anger, anxiety, and social isolation. And the interventions improved well-being, improved quality of life, and they complemented the benefits of exercise training, but did not seem to alter prognosis. However, there's a very recent Swedish randomized trial of cognitive behavioral therapy that showed a decreased risk of recurrent events. Again, very different population to the ones you and I see in the office. Let's talk about special populations. And first is women in cardiac rehab. Women, and in particularly elderly women, those are the coronary patients, less likely to be referred by about 55%, less likely to attend, and less likely to complete, even though men and women benefit equally. Non-white women have lesser referral and a greater likelihood of financial barriers. But in the 2011 prevention guidelines, specific recommendations were made for women for cardiac rehab and exercise training. Older adults, that's your population here in Florida. Older adults have an increased risk of disability after a coronary event. And about half of the patients eligible for rehabilitation are in the Medicare age group. There's less referral and less participation, even though older patients have comparable trainability to younger patients. Those older adults who are referred have high attendance and no increase in complications or adverse events. And within a rehab program, they require only modest modification in prescription training. It's really as we do with medications, start low and go slow, and limitation of high impact activities. There was a database in the Medicare population, some 600,000 patients who were hospitalized with coronary disease. And for those who participated in a secondary prevention or rehab program, 21% decrease in 5-year mortality. Very impressive. And again, meta-analyses, about 20% decreased mortality compared with age-matched older adults if they participated in secondary prevention cardiac rehab. So with the potential benefit, with the safety, and those long list of barriers, we looked for alternate and novel modes of delivery of cardiac rehab. The first ones were home-based programs with a nurse case manager to supervise and monitor programs. There was early telephonic transmission of electrocardiograms. We began to see community-based group programs that did not involve a physician, guided by nurses and other providers. And now that is legal and reimbursable. Very new change. Then we began to see internet-based programs, computer-assisted home-based exercise, electronic mail, social media, remote exercise surveillance, and diet and lifestyle coaching, comprehensive risk management and education, again, internet-based, and some guidance for structured exercise. Then, again, much more recently, we began to see smartphone app-assisted exercise, and I'm going to talk about that in a minute. But what we saw is that individualized increase in daily lifestyle, work and leisure, trying to get to the goal that we have of 10,000 steps daily. And the data on benefit really come predominantly, not from the US, from the United Kingdom, but for low to moderate risk coronary patients in the UK, working patients preferred medically directed home-based as compared with center programs for a whole variety of reasons, mainly access and convenience. And there was similar adherence to supervised exercise regimens, home-based and center-based. So fairly strong data about that. And then obviously, as we use technology, it's less personnel intensive, more convenient, lower cost, very acceptable. Safety data, although they're limited, seem good. But the importance to me is that this emphasizes independence in exercise, self-reporting, so that the patient now becomes in charge. And we're using web-based technologies, mobile information devices, and smartphones have really come into their own. What we see is that the technology can collect and summarize the self-reported information. It can provide coaching and case management. It can provide education and ongoing feedback, both to patients and to their practitioners, and can be individualized to a patient needs, yet maintain standardized care. And in early studies, most not in the US, it has been shown to be cost effective. Let me just end by telling you some of the things that we're doing at Emory now, because we started this a long time ago, and I think we've come full circle. We have done a study of smartphone-enabled cardiac rehab in veterans with ischemic heart disease at the Atlanta VA hospital. The reference is at the bottom. It was a prospective interventional home-based 12-week program, 16 patients. The app-based reminders to exercise. There was a virtual exercise diary, and there were educational modules incorporated. The patients had it was a hybrid program, coach monitored, because it was a web-based dashboard and pre-scheduled telephone visits. Of these patients who agreed to participate, there was 100% participation. They did a mean of 3.5 exercise sessions a week. The exercise capacity, and this is 12 weeks, increased a mean of 1 MET, and there were no adverse events. And about 4/5 of them were satisfied with the program. So we're beginning to see this is feasible. The Million Hearts program is starting this in many other centers. And we're doing something else. The Woodruff Health Sciences Center at Emory has a Synergy Award, which we competed for and won. It has to involve at least 2 schools and several departments. And what we submitted as our proposal was smartphone-enabled supervised exercise therapy for the treatment of symptomatic peripheral arterial disease. You know, these patients have such difficulty getting to exercise sessions, and we thought that this might be a very nice study. We're planning to randomize 50 patients to smartphone-enabled therapy versus the standard recommended home exercise for 12 weeks. The smartphone app has daily reminders to exercise. There's a virtual exercise diary that involves time, duration, and symptoms. And there's 2-way secure, HIPAA-appropriate messaging with a healthcare coach. The one thing that we don't have here, and we're trying to put it in, but so far limited, is trying to set up a chat room on the smartphone so that the patients can communicate one with the other. And since that's patient initiated, it doesn't have to be HIPAA compliant. The endpoints for this study will be the 6-minute walking distance, an objective measure, pain-free walking distance, again, an objective measure, and self-reported quality of life. So this is a matter of stay tuned. We should have these data. But if we want to examine cardiac rehabilitation over the generations, in the early 20th century, we saw rehabilitation in the castles in the Black Forest. Late in the 20th century, we saw rather sophisticated and probably over-monitored hospital-based and center-based rehab. And in the 21st century, I think we're going to migrate to the smartphone or other technology, and I expect that this will improve patient care, patient access, and patient satisfaction. And I thank you.